Hi, this is Andrea Kane, and I'm here with you for HIT 421 Legal Aspects of Health Information. We are now on week 14, which is Chapter 16 Required Reporting and Mandatory Disclosure Laws. If you are looking at your syllabus, you'll see that this week we are focusing on Unit Objectives 9.8.1 through 9.8.11. If you would like to open your book and follow along with me, I am starting on page 383. There are required reporting rules for different types of PHI, and that's really what we're going to talk about this week. Federal and state laws require reporting certain PHI to protect the health and safety of a community. So when you're thinking about this topic, be thinking public health, safety, think the law, the judicial process, as well as law enforcement, research, and workers' comp. If you think about those four areas, you pretty much have all of the required reporting that we're going to talk about. Information that's collected in this manner is not considered public information, and patient privacy and confidentiality are protected, meaning that even though PHI is disclosed, it is not made public. So for instance, you can find out the number of measles cases in your state, but you can't drill down to the point of finding out who had those measles cases, even though healthcare providers did provide that level of detail. There are some times when disclosure occurs without patient authorization or agreement. We've already talked about some of the ways that patients can access, use, and disclose and authorize their information and how it's used. In this case, in Chapter 16, what we're talking about are situations where the patient does not have the right or the authority to be able to authorize or disagree. This reporting happens because of the law. So there are 12 public interest and benefits activities that are exceptions in the HIPAA privacy rule. Individuals cannot agree or object to the disclosure, and no authorization is required. The amount of information that's disclosed, or the PHI that's disclosed, is defined by state law, public health, or serious threat to health or safety. The topic of preemption, we've talked about this before. This provides that federal law must be followed when state and federal laws conflict unless the state law is more stringent on the matter than federal law. So what this boils down to is if you're lucky enough to be in one of those states that really spells out a lot of things and really goes into more detail, then you follow your state laws. If your state laws are kind of pathetic and they really don't address it, and HIPAA does, you follow the federal law or HIPAA. So that's what preemption is all about. We've talked about that before, but it also comes into play here when you're talking about mandatory reporting laws, because you may have state laws that require mandatory reporting on 50 different things, whereas the federal law may only cover 12 or 20. State law will prevail if there are provisions of state law, including state procedures for reporting of disease or injury, child abuse, birth, death, or for the conduct of public health surveillance, investigation, or intervention. So in these cases, those things that are written there, and this is the Federal Code of Federal Regulations, this says that state law always prevails when it's coming down to these topics. There is we'll talk about this when we get to vital statistics, but there are some federal laws that are overarching, but they don't get into as much detail as most state laws do when it comes to vital statistics. So, notice of privacy practice. Under HIPAA, generally, an individual has the right to adequate notice of the uses and disclosures of PHI that may be made by the covered entity. So what this means is when you're doing your notice of privacy practice, it has to contain in there a list of the uses and disclosures of their PHI that may be made. And this is where patients can find out about the fact that certain things are reportable to the state for public health or for workers' compensation or for law or law enforcement, those types of things. And so it should state that under the Notice of Privacy Practices. It doesn't mean that they have a right to agree or disagree to it. It's simply that we've made them aware that these uses and disclosures may be made. And so, yeah, it's just really informational. Accounting of disclosures. The privacy rule requires the tracking of disclosures of PHI that are made in writing, electronically, by telephone, or orally. The exclusion to this is treatment, payment, or healthcare operations. So in those cases, there is not required tracking of disclosures. However, a lot of organizations do tend to track those disclosures and have them in their system. Whether they disclose those to the patients or not is really up to the organization. They're not required to keep that under HIPAA. However, anything other than treatment, payment, or healthcare operations, they have to track those disclosures in a central tracking system that enables multiple departments to record disclosures. So for instance, if you have quality management that's disclosing PHI for one of their purposes, you have infection prevention or infection control reporting for those purposes like public health. You may have HIM that's releasing records for workers' comp. Those types of things, they may be covered under operations, they may not. And so it's important to kind of clarify what those are and whether or not they'll be in the accounting of disclosures. When it comes to abuse and neglect of children, pretty much every state has a law about that. And not only is it required to be reported to the state, it's also required to be reported to law enforcement. And each state will lay out exactly what is required, who must report, within what time frame they must report, exactly what they must report, and who they report it to. Types of neglect that are included under abuse and neglect of children include neglect, physical abuse, sexual abuse, emotional abuse. And a child is defined as any person under the age of 18 or physically or mentally handicapped up to the age of 21. So again, state laws define who must report. There is protection from liability for reporting in good faith, and there are privilege exemptions. Remember, we talked about physician-patient privilege. Abuse and neglect is one of those topics that the law says you have to break that privilege and report. It has to be orally reported immediately with written reports in a prescribed time frame. There is no conflict with HIPAA regarding authorization for disclosure due to public interest and benefit exceptions. So when you're reporting this, you're reporting it under the law. You don't need patient authorization. You don't need to alert anyone. You just simply follow the law and report. And this is typically handled in the ED or by social work. You'll find out what your organization's process is once you get there. There's also abuse and neglect of the elderly and disabled. This includes individuals 60 years of age or older, or a disability that's attributable to a mental or physical impairment that results in functional limits, meaning that they have difficulty with their activities of daily living, their ability to do all of the things that they would need to do for themselves to thrive. Types of abuse that are included under abuse and neglect of the elderly and disabled include physical, emotional, financial, sexual, neglect, abandonment. There are laws covering abuse in the home setting, known as domestic abuse, versus abuse in institutional settings, such as nursing homes or group homes, or even a hospice facility. State laws also vary regarding required reporting of abuse with the elderly and disabled. There is, again, no conflict with HIPAA regarding authorization for disclosure due to public interest and benefit exemptions. Vital records. These are required by state and federal law. The National Center for Health Statistics, NCHS, is responsible for working with state vital statistic laws and agencies and making sure that everything that's being gathered can be funneled up to the federal level and be published that way. So even though on a local state level you have PHI being gathered, what gets reported up does not include PHI. So some examples are birth certificates. Every live birth has a birth certificate, and by live birth, that is when a child is born, their APGAR is above 0. If their APGAR is 0, they're considered a stillbirth after, I think, 22 weeks of pregnancy. But every live birth has a birth certificate. There are 2 parts to the certificate. The top part is the identifying information about the child, what the child's going to be named, the date and time they were born, the location where they were born, their parents' full names, parents' dates of birth, parents' places of birth, all of that kind of information is all on top. The bottom part is all about the mother's pregnancy and any birth defects of the child. So, for instance, if the mother had gestational diabetes, or if she was unfortunately addicted to a drug and utilized that drug during pregnancy, so there was substance abuse there, all of that gets reflected in the bottom of that birth certificate. And when the birth certificate gets to where it's meant to go, back in the days of paper, it was sliced, and the top portion was sent to one area where they recorded the information, and the bottom went off to the state, so that even though it was submitted as PHI and identifiable, once it moved into the process, it was no longer identifiable for the pregnancy and birth defects information. Because really the state is gathering that to trend it, to see what can be done. Is there an area of concern? Those types of things. Laws define how a father is acknowledged and what surname is entered in for a child, and that is all based on state law. Having worked in multiple states, I can tell you that. In one state that I worked in, if the mom was married at the time of conception or within 10 months of the baby's birth, the father's name had to appear on the birth certificate, the husband. He may not have been the father of the child, but because the mother was married, she had no choice legally but to place her husband's name on the birth certificate of the child if she was married. I've been in other states where mothers can then choose to leave the father's name off and his information off, and an affidavit of parentage can be done later. So it just varies, and you have to kind of know what your state laws are to know what to follow. And most birth certificates are filed electronically these days. The information might be taken off a paper document that the parents have signed or the mom has signed, and then it's inputted in to the system. Or it may be that the preliminary information is entered into the system. A paper copy may be printed off, the parents or the mom signs it, and then it's scanned and uploaded to the state. Death certificates. These are usually completed by the funeral director. They include PHI about the deceased, as well as information about the cause of death. The attending physician, or whoever pronounced the patient typically, has to provide the cause of death and sign the death certificate. So where HIM sees activity with this is if the funeral director is trying to track down the signature or the diagnosis from the physician. And so sometimes we end up being the middleman in there, trying to help the funeral director get the information they need, either from the record or from the attending physician or pronouncing physician. But it's completed by the funeral director, and then they file it with the state. And so, of course, it gives PHI about the individual who died, and usually a couple of spots where they can put in diagnoses as the main cause and maybe some subsequent influencing conditions. When it comes to communicable diseases, these are transmitted from infected person, animal, or inanimate reservoir to a susceptible person or host by either direct or indirect contact. State laws define which diseases are reportable, by whom, and how they should be reported. Also have provisions to keep the information confidential. Because again, like with COVID and measles and tuberculosis and things like that, infection prevention or infection control has to report those, and they have to report the PHI, because sometimes, like with a measles outbreak, or even another good example would be food poisoning. Sometimes you'll have an E. coli outbreak in an area, and they'll want to try and identify the individuals who are involved and go back and question them as to where they had eaten or what they had eaten to identify where the food poisoning occurred and how it occurred. But even though they get that PHI, they keep it confidential, and what is actually made available to the public later is simply the number of cases, not identifying who had those cases. So notifiable diseases are classified according to their potential for endemic or epidemic, or in our case with COVID, pandemic spread and danger to public health. And typically they're reportable within 24 hours. When it comes to induced termination of pregnancy, also known as abortion, state law requires that healthcare organizations where induced terminations or pregnancies are performed have to report the termination. And I find this interesting because state law does not require these same organizations to be accredited or to be licensed by the state with any kind of surveys to verify or validate their organization as you would see in any other healthcare organization. However, they are still required to report the terminations. The information that they typically report includes date of birth, race, marital status, county and state of residence, the type of procedure performed, and the resulting complications, if any. And then, of course, again, this is PHI that gets reported, but the state strips that off to then just report statistics. Birth defects. This information is usually obtained from birth certificates filed with the state where they're looking to determine trends in birth defects and look for ways to prevent them. And again, that information does go all the way up to the federal level because they're constantly looking for ways to decrease birth defects. Reportable deaths. There are types of deaths that must be reported depending on your state's laws. And they'll tell you what those deaths are and what information must be disclosed and whether or not you're to disclose it to law enforcement directly and within a certain time frame. But the typical deaths that states want to know about include accidental death, homicide, suicide, sudden death, suspicious death, death from abortion, or induced termination of pregnancy. We've talked before, I think, about medical examiners and coroners. Medical examiners are typically a physician with pathology training. A lot of times you'll see hospital pathologists who moonlight as medical examiners as sort of a second job and a way to bring in some additional income because they're so used to doing autopsies. They had to do that for college training. And even if their facility, their healthcare organization that they work for, no longer does autopsies, they can still be medical examiners and perform autopsies. The coroner is typically an appointed or elected official who may or may not be a physician. I worked closely with a medical examiner who was not a physician in the state of North Carolina and knew him very well. He was actually a medic with Special Forces for about 22 years before he went into OR nursing and moved up into a director position. So he was director of the OR. And occasionally we needed to notify him, and he would let us know that he would need some medical information, some PHI, because he was going to be doing some investigation. But either way, both have responsibility for investigating suspicious deaths or unexplained deaths. Maybe that's a better term, as unexplained or questionable, perhaps questionable. Anyway, MEs and coroners have the right to receive PHI that's needed to investigate the case without authorization, and they may actually have subpoena powers to collect such information. I've always had good relationships with medical examiners and coroners in all the states that I worked in. We never required a subpoena unless it was something that was really unusual. Usually they would fax over the paperwork showing that they were doing an investigation, and we would provide the PHI. But again, every state does it differently, and so when you finally get to whatever facility you're in, if you're involved in reportable deaths or working with medical examiners or coroners, you'll learn the process for your state as well as your facility and how they handle those. So some common information that's reported to the ME or coroner includes name and address of the deceased, age of the deceased, marital status, ethnicity, time of accident or onset of cause of death, place, mode, and manner of injury, place of death, time of death, location of body, anything else that may be pertinent to it. You know, if they had been in the ED 3 days earlier, they definitely will want that information. If they had been visiting someone in a nursing home and there had been some kind of flu outbreak or COVID outbreak, that would be pertinent data too. The name of the person reporting the case, including date and time, and the name of the physician who pronounced the person dead. So that's all information. I mean, there's additional information as well, but this just gives you a good list to go off of. There are state requirements for reporting of wounds, knife, gunshot, and burns. Even if they weren't caused by a crime or alleged to be by crime, states still typically want to know about them. You know, sometimes there can be accidental gunshot wounds where maybe someone's cleaning a gun and they shoot themselves in the foot, so to speak. You know, that's still reported because they want to investigate and find out what's going on with that. And same thing with a knife. You may have someone who cut themselves when they were working in the kitchen, but it may still need to be reported depending on how bad it is and what the situation is around it. Again, they just want to make sure that there's not some type of domestic abuse going on or that there's some kind of criminal activity that they need to investigate. And with burns, you know, perhaps if someone has an accident and they burn themselves at home, you know, even though it doesn't seem like it would need to be reported, state law may require it to be reported because they report all burns. It could be a situation where there was some arson involved. You know, obviously, when you're treating patients in the ED, you don't always get the whole story because you're focused on getting the patient the treatment that they need. But state law will tell you what you need to report and when it needs to be reported and to whom it needs to be reported. Any type of unusual events, other instances that might assist with public health prevention and control programs may also be required as reporting. And again, you'll just learn that as you practice HIM in whichever state you end up being. Fetal deaths are also required to be reported in every state, and this means the death of a preborn child that is 22 or more completed weeks of gestation. This means a child that's born with an APGAR of 0. So if it's an APGAR of 0, it's considered a fetal death or a stillbirth, and there still has to be a fetal death certificate completed. Typically, that's done by the funeral director, and you know, they gather the information just as they would with a death certificate, working with the family, working with a physician who was in attendance. If it happened at home, let's say that someone delivered at home, then the medical examiner has to be notified, and they're the ones that will then end up completing the death certificate. So what are some of those unusual events or other state reporting requirements that you might run across? Well, medication errors that result in death, transfusion reactions that result in death, falls that result in severe, significant fractures, not like a broken finger or broken hand, but we're talking about, you know, maybe severely broken hip, those types of things that may end up resulting in death. Anytime there's wrong patient, wrong site surgical procedure, your state may require you to report it, and operative complications. An example of an operative complication that you may have to report is, for instance, people who have an abdominal aortic aneurysm. If that ruptures, you can take that patient to surgery, and there's a very, very, very slim chance that they will be okay, because just by the nature of that situation, of the diagnosis and the rupture and how it affects the body, most of those patients do not survive, even if you take them to surgery. So that may be an example of where it's a death in the OR, and then your state may require you to report it. It isn't that you did anything wrong. It's just that the fact that these things happen, and the state has the rule that they have to be reported. And probably the state will investigate them. Just FYI, you can probably bet that there's going to be a state surveyor that shows up on your doorstep sooner rather than later to investigate. Some states have implemented prescription drug monitoring programs, and this is a really great thing. I was in North Carolina, and they had one of these. It was a benefit to the ED physicians particularly, but also to primary care physicians. Prescription drug monitoring programs require pharmacies to report to a state data bank controlled drugs that they receive a prescription on and fill. And the reason why this is important is because some patients who are on opioids have gone what is called doctor shopping, and they have obtained multiple prescriptions for opioids from multiple doctors. And in their defense, some of these doctors truly did not know that this patient had been already prescribed opiates from another physician. Once they investigated and started tracing back, why could one patient have 5 different opiate prescriptions from 5 different doctors? So what they did was implement this PDMP, or Prescription Drug Monitoring Program, and require that physicians, particularly in the ED and in primary care or family care, primary care, that they would check this before prescribing any opiates or opioids to patients. Some patients, it's because they're taking more of the drug than what was prescribed. We've talked about that. If you're in pharmacology, you've talked about that, about how patients develop what's called tolerance. It may also be that some patients are selling the additional drugs on the side to help fund what's going on. So that's really a great program. But again, that's one example where PHI is going to a state data bank. When it comes to the Nuclear Regulatory Commission, they have oversight for medical use of ionizing radiation. And where this affects healthcare organizations is if you have an oncology program that also uses radiation therapy, or if you have a radiology department that has a nuclear medicine section. Again, nuclear medicine is used for stress tests, it's used for brachytherapy, and radiation therapy is used for all sorts of different types of cancers. Medical centers have to report to state agency and the Nuclear Regulatory Commission anytime there is any misadministration of the material, or if you've had some kind of accident or leakage or damage to radioactive materials or equipment. You have to do that. And there's a whole bunch of rules that govern using ionizing radiation or nuclear medicine, the isotopes, the radioactive isotopes. I've worked with several organizations who have had that. And at one point, we were redoing a radiation therapy department, and all that goes into the calibration, you get the nuclear physicist who literally comes in, and he's a nuclear physicist, and calibrates the equipment, looks at everything, checks off on everything, has to come back periodically and do that. Yeah, it's very involved. PHI, as it involves workers' comp. Anytime that someone's injured on the job or becomes ill as a result of their job, they are provided with some means of support while recovering from illness or injury. That's the purpose behind workers' comp legislation. And where we've actually seen quite a bit of activity in this area during COVID is for those individuals who were on the job and became ill with COVID because they were on the job and were exposed on the job. So actually, workers' compensation has sort of come to the forefront with COVID in different applications. And when workers' comp, if you think about it, is state-based. And so the state rules, the state is the one who would be paying the benefits, and they're involved. So they have the right to mandate that PHI related to that illness or injury that occurred on the job be released. Now, granted, they still keep it confidential, but as it goes through the workers' compensation process, the employee or their representative cannot argue. Because when they file their claim, they have to sign authorization to release the medical information to workers' comp. If they don't, they can't, their claim goes nowhere. So in order to file their claim, they have to sign that authorization authorizing the release of that PHI. And, so that goes hand in glove. The information may then be disclosed to other state or federal agency without patient authorization if it's part of the workers' compensation process. Anytime there is a serious occurrence or death related to restraint or seclusion, there is a boatload of reporting requirements that go with that. COPs, or conditions of participation, require accredited hospitals deemed to meet Medicare requirements have to report deaths from restraints or seclusion to CMS by phone within 1 business day. They have to document in the patient's health record the date and time that the death was reported, and they have to record an internal log system within 7 days of death with key patient information. Restraints and seclusion are nothing to fool around with. The documentation required for that, both on a federal and a state level, not to mention accreditation level, is just unreal. There are so many hoops that have to be jumped through when you're talking about restraint or seclusion. When it comes to children, that's even more detailed, strict, crazy. But the Children's Health Act of 2000 restricted the use of restraints and seclusion in all psychiatric facilities that receive federal funds and in non-medical community-based facilities for children and youth, meaning that the use of restraints and seclusion is restricted to emergency situations only, and that means that they can only restrain that child or youth for 1 hour. That is the maximum. That's what it means by emergency safety situations only. They have to notify the family. There has to be a physician that gets there within an hour and assesses. And there's a whole lot of other, they have to do a debrief with the family. They have to do a debrief with the patient. There's just, there's so much that goes with that. Quality measures. There's national reporting required of quality measures, and this does include PHI. Quality measures for CMS, Joint Commission, and other entities required that hospitals, physician offices, nursing homes, and other entities for the purpose of improving the quality and safety of patient care disclose this. They use it for retrospective analysis, real-time reporting to comprehensively evaluate and manage quality improvement efforts. Things like this would be like VTE measures, congestive heart failure measures. There's a whole list of them that fall under that. But the data is submitted to federally supported quality improvement organizations, QIOs, clinical data abstraction centers, CDC, and others. Quality measures continued. The 2010 Affordable Care Act established mandatory quality reporting requirements for long-term care hospitals, inpatient rehab facilities, and hospice programs, all starting in 2014. This probably will continue to advance as time goes by. Hospitals were already required to do this mandatory reporting, so it's not surprising that they expanded it, and they will continue to expand it. If you fail to comply with the data reporting requirements, you are subject to a 2% reduction of reimbursement. I worked for an organization that unfortunately made the choices of not reporting, and they lost about $100,000. And there are others who have lost even more than that. So it's serious business. There are programs that are designed to prevent fraud and abuse, and these healthcare organizations have to provide copies of PHI or health records when they are arguing their case for reimbursement. And this includes your interactions with RACs, MACs, and MICs, Recovery Audit Contractors, Medicare Administrative Contractors, and Medicaid Integrity Contractors. So lots of records, you code them, you bill them, then you get this notice that the RAC is taking money back, or the MAC. is trying to take money back, or the MIC doesn't like what you did, and you have a choice. You can appeal it and try and win it. Been there, done that. And then there are times where, you genuinely probably made a mistake and they are going to just be able to take the money back. But either way, if you to begin with, when they request the information, when they're trying to decide, when they're auditing whether or not they're going to take the money back in the first place, you have to provide copies of those records, the PHI of those records. And then through the appeal process, again, you may find yourself submitting copies of different pieces of PHI to bolster your case as you're going through the appeal process with that. Purpose of the programs are to measure, prevent, identify, and correct incorrect payments under the Tax Relief and Healthcare Act of 2006 and other federal healthcare reform legislations. It's good. These are good programs. Don't get me wrong. They are good programs. They're there to, there as a system of checks and balances, because humans make mistakes and humans are the ones who do all of this. And so they're not necessarily there to give you a difficult time, although some do seem to do so at times. I've been involved in organizations that have taken cases all the way up to the administrative law judge, ALJ level of things. So I get it. But I've also been in the boat where, the first time it comes through from the rack, you look at it and you think, we just really missed that. We really made a mistake and missed that. So all in all, choose to look for the good. National Practitioner Data Banks, as we talk more about medical staff credentialing and privileging, and we talk about how physicians are licensed and that whole thing, you'll run across the National Practitioner Data Bank. This was created by the Healthcare Quality Improvement Act of 1986 and expanded by the Medicare and Medicaid Patient and Program Protection Act of 1987. The purpose was to identify and discipline those who engage in unprofessional behavior and restrict ability of incompetent healthcare practitioners to move from state to state without disclosure or discovery of previous medical malpractice payment and adverse action. There has been, unfortunately, a history where providers who were sanctioned in one state turned around and left, went to another. And because there wasn't a national data bank, excuse me, they continued their very poor care in the state that they moved to. And hospitals who hired these practitioners, not just physicians, but all practitioners, whether you're talking PAs, nurse practitioners, physicians, or what's the other one? Oh, it includes certified nurse midwives. It includes anesthesia, CRNAs. All those are included when it talks about practitioner. But anyway, this data bank was created to prevent providers from going state to state without it being aware of. So whenever there is a provider who has a malpractice payment or an adverse action, it gets reported to the National Practitioner Data Bank. And you're required, when you credential and re-credential a practitioner, you have to go out and query the National Practitioner Data Bank. The information that gets reported there obviously would include some PHI, and it does go out there. But again, when you go out to look, what you see in terms of PHI is kind of limited when you go out to query it for credentialing or re-credentialing. And this just talks how it goes on, that they merged, and there was an additional act in 2000, and then they began collecting fraud and abuse data and final adverse actions and different things like that. So the information that's reported to the data bank is considered confidential. It's not disclosed except as specified by regulation, but there are requirements as to who must report, what information they have to report, and what versus what's available, and then who can query the data bank. You have to have they take you through a vetting process, and you have to go through several levels before you get permission to be able to query the database or the data bank. Then let's talk about medical device reporting, because that's important too. The Safe Medical Devices Act of 1990 required reporting to the FDA, the Food and Drug Administration, and the product manufacturer of the medical device, any occurrences that have or may have contributed to serious illness, serious injury, or death, including occurrences attributed to user error. They then went on to pass some additional amendments in 1992 that clarified the terms, established a single reporting standard for device users, manufacturers, importers, and distributors. A medical device is anything that is used in treatment or diagnosis that is not a drug. So this includes x-ray machines, sutures, defibrillators, grafts, syringes, lasers, heating pads, bone screws, pumps, anything like that. The FDA requires specific information to be reported within 10 days, and they're all listed for you here. User facility report number, name and address of the device, manufacturer, device brand name and common name, the product model, catalog, serial, and lot numbers, brief description of event reported to the manufacturer and the FDA, and where the report was submitted. So you can imagine that in every organization, there is someone who has a database on medical devices. They keep track of all this information. Usually it's like in the OR, or depending on where it's used, but when you're talking about sutures, defibrillators, grafts, bone screws, those are typically in the OR. But anyway, they keep track of this so that if there is an occurrence, they can go back, pull the information, identify the information. And the other reason why you do this is recalls. If there's a recall on something, you've got to be able to go back, identify when and where the stuff was put into a patient, who that patient was, and how to contact them to alert them to the recall and what to do with the recall. So again, reporting is done through the Safety Information and Adverse Event Reporting Program, known as MedWatch. The FDA also encourages voluntary reporting of adverse events related to products or technology to MedWatch. The FDA does not regulate EHRs working with the Office of the ONC and FCC representatives to improve the safe use of EHR technology, but they encourage the voluntary reporting of problems with EHR. So even though the FDA doesn't regulate EHRs and any issues that occur with them, they still appreciate you letting them know, even if you're working with ONC and FCC and the Federal Communications Commission. All right, HIPAA allows medical device reporting without patient authorization, and obviously there's great reasons to do this. Like to collect or report adverse events, product defects or problems, or biological problem deviations, to track FDA-regulated products, to enable product recalls, repairs, replacements, or look back, and to conduct post-marketing surveillance. Under the Freedom of Information and Privacy Act, the FDA information may be accessed, but the FDA is required to delete any identifiable information, any personal, medical, or similar information that would constitute a clear, unwarranted invasion of personal privacy. Trade secrets and confidential commercial or financial information related to the manufacturer is also deleted, and any identifying information of the person that reported the event is also deleted. Let's talk now about organ procurement. Federal law requires that hospitals notify designated organ procurement organizations, or OPOs, in a timely manner regarding specified organ donors who die in the hospital or for whom death is imminent. And this is very serious. This is tracked. Hospitals have to do this. When they fail to do this, they can get into deep trouble. Hospitals and the OPO must do annual death record reviews. The hospital is not violating confidentiality by calling the OPO and providing information about an individual who has died or is dying. There is no requirement in statute or regulations that the family be informed about the hospital's notification to OPO before OPO can be contacted. So again, if you have a patient who is dying or who has just died, the hospital is responsible for contacting the OPO. There's forms for this, and they will explain to the OPO what is going on with the patient or what conditions the patient had, and the OPO will tell them what the patient could donate. So, for instance, let's say you have a person who was in a car accident and who passed away, and maybe the family is intending to withdraw life support because of brain death. And the hospital will contact the OPO, and they will talk about whether this person is a candidate, that maybe their heart is okay, their lungs might be okay, um, that their eyes might be possible, that there might be some tissue that they could donate, those types of things. And the OPO will tell the hospital, yes, based on this, this patient or this individual who is dying or deceased is eligible to donate these 1, 2, 3, 4, 5 things. And then the hospital is responsible for going to the family and saying, is this individual a donor? And if they are, they explain to the family what could be donated, and the family can agree or disagree. Clinical disease and outcome-based registries. These are databases containing information about a disease or condition. They are used for a broad range of purposes in public health and medicine, from evaluating patient care to monitoring defective devices. They may be required by federal or state laws. The common requirement is that data submitted to the registry be maintained in a confidential manner and the identity of the patient is protected from disclosure. And typically what they will publish is just overall numbers. When it comes to implantable cardiac defibrillators, or ICDs, Medicare expanded its coverage of ICDs to eligible Medicare beneficiaries in 2005. Every hospital that seeks reimbursement for an ICD for Medicare must participate in this ICD registry. So obviously they're submitting PHI for this. So what other types of registries are out there? Well, there's cancer registries, trauma registries, immunization registries. In fact, Iowa has an immunization registry. Didn't know if you know this, but you can go out and I think the letters that you would type in are IRIS, IRIS. But you can go out and look at, just type in immunization registry Iowa, and you'll find out about that. Birth defects, diabetes, implants, transplants, and then there are also qualified clinical data registries. There are some disclosures to public health authorities that are not required by law. Covered entities may disclose PHI to public health entities even if the law does not specifically require the disclosure, if the disclosure is for the purpose of preventing or controlling disease, injury, or disability, including but not limited to the reporting of disease, injury, vital events such as birth or death, and the conduct of public health surveillance, public health investigations, and public health interventions, or at the direction of a public health authority to an official of a foreign government agency that is acting in collaboration with a public health authority. And I find it interesting. You'll see on our slide here, it's dated to copyright 2017. COVID was not in any state laws. But as you can imagine, when COVID hit, it became a public health concern. And so even though state laws did not say you have to report COVID within a certain period of time, they used this federal law for the CDC to come in and say, you will report this, because it absolutely has to do with public health. So there are times, and hopefully we'll never see them again in our lifetime, but there are times when, even though it's not laid out for us specifically in state or federal law, this federal law supersedes it and says basically if it falls into this category, you must report it without patient authorization. It's just going to be required, even if the law doesn't specifically name it. And that is it for Chapter 16. So hope you have a fabulous week, and we'll see you back next week. And we will tackle Chapter 17 and 18 next week. Take care.